Welcome again to the Weinberg Family Cerebral Palsy Center Lunch and Learn series. Today, we have the great fortune of hearing three outstanding talks from our nurse practitioners. They're going to talk about the roles of the nurse practitioner in the care of children and adults with cerebral palsy. We only have an hour, so we're going to try and move things along. Just to remind you all about the Lunch and Learn series, these are short educational topics that are related to the work that we do with people with cerebral palsy. I'll generally be hosting, but we're going to bring in guest speakers to talk about topics that we think are relevant, but also we want to know what you would like to hear about. So please feel free in the chat. You can put your ideas in. In the future, we're going to hear a session on medical management of spasticity, as well as another topic on surgical management of spasticity. But today we're going to hear from our three nurse practitioners. Nikki Bainton is going to talk about role of the nurse practitioner in the surgical setting. Elizabeth Bates will speak about the role of the nurse practitioner in physical medicine and rehabilitation. And then lastly, Eduardo Del Rosario is going to discuss the role of the nurse practitioner in the lifespan care of people with cerebral palsy. I imagine that the majority of you have had some interaction with our nurse practitioners, and that is your good fortune. If you have not yet, I think you're going to find this introduction to them really worthwhile. So let's start with Nikki Bainton. Nikki is the clinical team leader within the Division of Pediatric Orthopedic Surgery. She's been working with us for 16 years. She's an instructor at the Columbia School of Nursing and has been with us for over 16 years, and she has over 20 years of orthopedic experience. So we look forward to hearing from her and how she perceives and carries out her role in the care of people with cerebral palsy. Good.
So we're just going to start with what is a nurse practitioner. A lot of people may or may not know what a nurse practitioner does or is. We are highly trained healthcare providers who help bridge the gap between medical knowledge and patient-centered care. And what that means is we basically take all the medical information that you are getting and make sure you understand it at whatever level that you need, and also understanding that it's based on you and your children and what their specific care needs are. We have either a master's or doctorate level in addition to our bachelor's of science in nursing. So we are registered nurses in addition to our advanced level training. We practice independently and in coordination with our other healthcare professionals, including other physicians, athletic trainers, physical therapists, and other people. And then we are a pretty good portion of most of our multidisciplinary teams at Columbia. So my role of an NP in the surgical setting, I have a few hats that I wear. In the office, I help evaluate patients side by side with our surgeons. I work generally with Dr. Hyman and Dr. Benjamin Roy. And then I help the patients and the parents understand all the orthopedic issues that we're talking about in easy to understand language. We provide support when you're making the decision for surgery to help you make the decision for surgery itself, but also understanding what happens post-operatively so that you can make that decision based on timing and other psychosocial needs. We develop and provide those educational materials, usually in the form of a packet, regarding potential surgeries that we're recommending. And then we connect our families with our care coordinator in order to get services that they may need, appointments with medical specialists, especially if they're needed for preoperative clearances, and then other community needs. So preoperatively, I make sure that everybody's prepared for the surgery and that they understand the procedure that we are doing, and then also the potential outcomes, and also what to expect post-operatively, whether that is if they are going to be in casts, if they're going to be in braces, if they're going to be in any other implement that they would need to accommodate for in their homes. I provide support prior to the surgery and make sure that everybody is optimized by their medical specialists, and that includes any other specialist they may need, including pulmonary, cardiology, and sometimes we may have to shift their surgery in order to optimize them, because we want to make sure that they are medically managed before we embark on a big operation. I answer any and all questions about postoperative expectations, whether that's in the office, on the phone, multiple times on the phone. I'm happy to answer all the questions because I want to make sure everybody is prepared. So here are just some pictures of our pre and postoperative scoliosis, cerebral palsy patient. And then also one of our pre and postoperative hip reconstructions. So these are two of the bigger surgeries that we do, and that I help educate patients on. And then postoperatively, once they're discharged, basically all of their support comes to me. Any concerns, I see patients for their initial post-op appointments. We take the bandages off, we talk about wound care, we talk about pain management and medications, and that may mean adjusting medications, adding medications to help with tone reduction and spasticity. We talk about recovery goals and realistic timelines, and basically any anticipatory guidance of what to expect moving forward. And then I also, the other hat that I wear is research. But we work with a wonderful group of people here, and we do a lot of research that helps either one of the studies that we recently did was to try and minimize the number of visits you would need. So we've actually worked with cardiology to see if patients truly needed to see cardiology prior to some surgeries. And we found that, some of the patients didn't really need to be seen. So we were saving them a visit. Obviously people with cardiology problems need to see them, but for some of our patients, we were trying to limit the number of extraneous things they need to do preoperatively to help limit that.
All right, Nikki, thank you very much in describing a very broad portfolio that you manage. I neglected to mention to the audience that we'd like to hear your questions as well as comments, and you should see a question and answer button that you can push. I don't see that myself, but I do see the chat room. So certainly you can put questions in through the chat. Jacqueline, do you see question and answer?
Yes, I do. It's at the button on the bottom right of the screen. I think we have one question, so I'm going to go and take a look.
Yes, you know what? I see it now. Let's see, how do I? Close that. Let's see. If I can't get this open, Jacqueline, I may ask you.
I will direct the questions.
Yeah, please.
Yep.
Will you ask the question?
Yeah, okay, the first question is, what type of coordination is done to ensure educational gaps are minimized?
So I do a lot of in-person and on-phone discussions. I do a deep dive into their medical charts to make sure that they require pulmonary clearance, or if they haven't seen pulmonary in a while, that is done. I actually have a fair amount of discussions with our anesthesiologist and the nurse practitioners in the anesthesiology group with the Apex clinic, and between the two of us, we actually determine what is necessary for these patients. And then our care coordinator, Jennifer Pimentel from the CP Center, sometimes helps us coordinate all those appointments to make sure everybody's optimized.
Yeah, there's a great deal of communication that goes on in order to schedule a surgery, or even just in order to schedule an additional consultation visit with another service, with pulmonary medicine, cardiology, infectious disease, or with one of our very close colleagues, physiatry, or neurology. It takes a great deal of time as well as skill to know how to work within the system to help coordinate those appointments. Nikki, I want you to elaborate a little bit on this role of education, preoperative education. Tell us about some of the materials that you have created to help in this effort.
So I've made a few packets. They're booklets really, because they're pretty extensive. And it's a multitude of information. It includes making the decision for the surgery, what to expect. It includes x-rays pre and post-operatively. It also explains the surgery in detail in fairly easy to understand language. It talks about anesthesia and those requirements, the stay at the hospital. It talks about what is necessary before surgery, as well as what to expect post-operatively. It includes, the timeline of appointments post-operatively. It talks about frequently asked questions, what to expect post-operatively, and then also part of that frequently asked questions are actually questions that I've gotten from patients that I have compiled to include in there.
Yeah, I think that's really important. So, as I mentioned in the beginning, Nikki and I have worked together for 16 years. During those 16 years, we have both learned a great deal about the care of people with cerebral palsy, and we have benefited tremendously from working with each other. I find it's not at all uncommon that I will be talking with a patient about surgery, and Nikki will remind me about mentioning this, don't forget about that. And during the visit, you really have two people that you are consulting with, not just one. But also after the visit, there's a tremendous amount of work that goes on, if you will, behind the scenes, certainly behind the scenes for the patient, that goes into scheduling and coordinating the care. And I think you're going to find that's a common theme in the next two talks. With that said, let's keep things moving. I'm going to bring up the slides again. Hold on a second. Let me bring up the slides. No, it's not it. Where did they go? Are you seeing the slides now?
No, not yet.
No,
All right.
Dr. Hyman, while you're looking for the slides, we have another question from David. It's now on the chat. What qualities or skills make a nurse practitioner particularly suited to become a successful NP, especially in the care of patients with cerebral palsy?
I can help answer that later. I can help answer that later. I have a slide for that.
So Eduardo Del Rosario, who is our newest nurse practitioner in the Weinberg Center,
And the youngest.
Who is our youngest in tenure, is actually going to address that during his talk, and I think it's a really important one. But right now, what I really want to do is bring up my slides, and for some reason I'm having a little difficulty. I did share.
I can share the screen.
That's Outlook.
How about the bottom of that? The one on your right-hand side, all the way at the top.
Here we are. I had too many things open. All right, good. Now you can see this?
Yes.
All right, so our next speaker is Elizabeth Bates, and Elizabeth Bates is a nurse practitioner within the Department of Rehabilitation and Regenerative Medicine. The other name for this department is also physiatry. And Elizabeth has expertise in the management of spasticity and multiple ways of managing spasticity. She works very closely with Dr. Hannah Azizi, who is another member of the Weinberg Family CP Center. And we're going to hear from Elizabeth today and what her role is in the care of people with cerebral palsy.
Awesome. Thank you. Hi, everyone. So I just thought I'd give a quick overview to start about what is physical medicine and rehabilitation, shortened to PM&R. It's a little bit of a mouthful. As Dr. Hyman said, it's also known as physiatry. We're a medical specialty that's focused on function. So whether that be regaining function, maintaining function, or improving function, that's kind of our focus whenever we see patients. We do focus on conditions that primarily affect the musculoskeletal and neurologic systems, and a majority of our patients are people with cerebral palsy. Pediatric rehabilitation is a subspecialty of PM&R, and that's the department that I personally work in. And the care of people with CP often falls under this category because it is a pediatric onset condition. And then our treatment plans and interventions focus on enhancing quality of life in whatever way that means for the patient and their families. And then we're very goal-oriented specialties, so we often have discussions about goals and whether they're achievable, how we can achieve them, and try to help patients come up with different goals if they don't have them when they come to us. We can go to the next slide. So I just threw together a list of kind of the responsibilities of a nurse practitioner in PM&R. It's by no means comprehensive, but it gives a good overview of the things that we do. So first of all, in clinic, we do, like Dr. Hyman said, we see patients alongside an attending PM&R physician. That's Dr. Azizi. Some of you may know her well. And in this clinic, we do focus on lifespan care. So we see patients from babies well into their adulthood. I do also see patients independently. My clinic is more focused on pediatrics just because I'm a pediatric NP. I'm a little bit more limited in the ages of patients that I'm able to see. We also work with orthotists during clinic visits to decide optimal bracing strategies. We also do in-clinic botulinum toxin injection procedures. And then as Nikki mentioned very well in her talk, we offer support, anticipatory guidance, and education to our patients and their families. And then next, we do a couple of procedures. So like I said, botulinum toxin injections can either be done in the clinic or they're under sedation in the endosuite or OR, or in conjunction with orthopedic surgery with Dr. Hyman in the OR. We also do intrathecal backlift and pump refills and troubleshooting. I'll get into that a little bit more on the following slides. And then we do have administrative responsibilities as well. So a lot of care coordination within the department and other specialties. We're referring out to other providers as necessary, and then responding to messages, emails, phone calls in a timely manner. And then lastly, teaching and research. So we often have medical students, residents, fellows rotating with us. So a lot of that responsibility falls on the nurse practitioner to educate whoever is rotating with us, whether that be in clinic or if they are observing procedures. You can go to the next slide. Sorry, just drinking some water. So kind of the bread and butter of PM&R is tone management. Tone is abnormal muscle tone, which is caused by kind of a miscommunication between the brain and the muscles, or the spinal cord and the muscles. There are a few different types of tone. The two main ones that we focus on are spasticity and dystonia. So the nurse practitioner plays an important role in evaluating the patient and assessing which type of tone is present when we see patients in clinic. And then I included some of the treatments or interventions that we typically recommend here. So we do offer oral medications, like I mentioned before, botulinum toxin injections, intrathecal backlift and pump management, which intrathecal backlift and pumps are typically used for patients with more moderate to severe spasticity who need more systemic or total body spasticity control. And these are placed by neurosurgery, but then we manage the pumps once they're placed. And then if we need some help with other movement disorders or other types of tone, then we'll refer out to movement disorder specialists for further recommendations. Oh, and then one thing I wanted to mention, sorry, before we go on to the next slide, the nurse practitioner can do all of these things independently or in conjunction with an attending physiatrist, with the exception of botulinum toxin injections, but we do assist with these procedures. So then the next few slides, I just wanted to briefly touch on some of the things that we may talk about if you come to see us in clinic. So like I mentioned before, we work with an orthotist. An orthotist is a trained healthcare professional who specializes in the fit and fabrication of different orthotics for the different extremities. So we may recommend different types of orthotics based on the goals and function of the patient. We work closely with our orthotists here in our clinic. And then I just included some pictures here. I won't go into too much detail. I know we don't have a ton of time, but just a few different pictures of the different types of bracing that we may recommend.
You have time. Tell us about these different braces, if you would.
Okay, sure. So the tall one, the leopard one, that is we call an ankle foot orthosis, shortened to AFO. This goes right below the knee, and this particular one is more of kind of like a ground reaction, kind of like modified AFO, and this would help patients who have difficulty with ankle movement or foot clearance when they're walking. So that might be recommended for someone who maybe is dragging their feet when they're walking or just need a little bit more help with that ankle range of motion. And then we have the short one in the top right, that's a supramalleolar orthotic or SMO that goes right above the ankle bones. And these ones we typically use for controlling kind of like pronation or supination of the foot or ankle. And then the bottom right, I just included kind of a pediatric version of that previously mentioned AFO. This one happens to be a solid one, but we do recommend hinged ones as well that have more movement in the ankle. All right. And then we will probably most always talk about different types of therapies when you come to see us. So the three main ones that we talk about are physical, occupational, and speech therapies. But we do often discuss aquatic therapy, which is wonderful for kind of stretching and strengthening of the muscles, as well as motor planning skills for people with cerebral palsy. And then hippotherapy, which is horseback riding therapy, which is wonderful for strengthening the core, head control, and kind of giving the person the ability to be in that upright position. We do work very closely with patients' therapists. They see the patient more frequently than we do, so we often consult with them, especially when we're planning for botulinum toxin injection procedures. We like to get their input on which muscles they think would be best to be injected in order to help the patient be able to participate better during therapies. Next.
There.
All right, and then I just wanted to touch briefly on serial casting as well. Serial casting is often used more for joint contracture, so meaning that the muscle has been tight for an extended period of time and it gets kind of stuck in a certain position and the range of motion is very limited. An example that we typically see is ankle contractures, so plantar flexion contractures, meaning that the foot is kind of stuck in a pointed position and we aren't able to flex it backwards. And serial casting is a series of casts that are applied in 1 to 2 week increments over a period of 4 to 6 weeks. And the goal is to provide a sustained stretch to the affected muscles and tendons to improve the range of motion. And this can be done as either a standalone treatment or after botulinum toxin injections when the muscles are more flexible and can sometimes be a little bit more comfortable for the patient. We do this in our department, but orthopedic surgery does this as well. And then just to wrap up, that was a very brief overview of all the things we do in PM&R. I just wanted to kind of plug a couple of special interests that I have. I'm a certified yoga and meditation teacher, so I have a special interest in accessible yoga. So whenever I see patients, I like to think of their care from a more holistic point of view and kind of come up with different strategies that we can do to help improve the patient's well-being and quality of life in whatever way they think would be best for them. So that's it.
Terrific. Elizabeth, thanks very much. So I think that in listening to both Elizabeth and Nikki's presentations, you get a sense that they really work very closely alongside both the physiatrist as well as the orthopedic surgeon and help to increase our bandwidth, if you will. So there's really just myself and Dr. Azizi, and there are a lot of patients, and it's really only with our nurse practitioners that we're able to see and help as many of them as we are. So another term for nurse practitioners sometimes are physician extenders, but they're obviously much more than just an extender, but they really do essentially what we do, and therefore help us to see more patients. Eduardo Del Rosario, who's going to speak next, is a little bit different. He actually has a whole series of skills and experiences that are certainly beyond mine. And that is really his interest and experience in working with people who are transitioning from childhood to adulthood, and also adults with cerebral palsy. He's been doing this for over 2 decades in New York City at NYU, and also at
Shriners.
at Shriners in Oregon, NYU in New York, and Elizabeth Seton as well. And he's going to discuss now his experience in transitional care and working with adults. I'm going to turn this over to Eduardo.
Hello, there first. So actually the first slide is the answer to the one question. So I am a family nurse practitioner, and I defined that a family nurse practitioner, that's from the American Association of Nurse Practitioners. So it's an ANP. Okay, so now, if a nurse practitioner wants to specialize, let's say, in pediatric orthopedics, unlike in medicine, you can be board certified for that. But in nursing, what we have is Duke University that can give you, you have to be a nurse practitioner and then can get a certification for 1 year in orthopedics, not necessarily pediatric, but that can help if you want to do that. And another example is becoming a neurology nurse practitioner. This board certifying entities can provide the certification, however, not necessarily just for pediatrics. So this will be more of a general, and then you as a PNP or adult NP, you can specialize. There are special interest groups. I just gave an example, which is NAPNAP, and that's for pediatrics. American Academy and of Cerebral Palsy and Developmental Medicine, we also have a special group there as nurse practitioners. Although it's not specifically nurse practitioners, but certain, let's say, for example, ITB group, there will be a group of nurse practitioners in that area. So that's this slide that we have right now kind of explains that. Now, the next one. So this is a drone view of my role in CP, and you could see the arrow going to the right. I started off in clinic, and then the next one was in education, and then finally research. So from a general view of it, I'm in clinic. I help out with lifespan care. And then in clinics, we also do QI and clinical pathways, and we also do programs. Those areas are actually born out of need in clinic. We will identify these needs, and then we will try to do the programs. And then in education, a nurse practitioner can lead a CME. What I know, because I've not tried the other institutions, but mostly to be a director in CME, it has to be an MD. But we can co-direct as PhD or NP providers, and then we present in national organizations, and we are like Nikki and I think Elizabeth also were all preceptors. And then research. Research was the last area that I kind of developed with a former researcher at NYU, Debbie Sala. I owe a lot to her. Mostly a lot in healthcare transitions, spasticity treatment, social determinants of health, and social prescription. So this is in action, a little movie. And then here, this is now a little bit more, not quite myopic view, but this is the areas that when I see a patient, this is what I apply. So there's orthopedics, there's neurology, there's rehab, there's part of the medicine and the social prescription. So they're self-explanatory. Maybe the social prescription may be different. Social prescription is, I believe that if we integrate the family, the patients in the community and the programs, these are all non-clinical, this is very helpful. So that's one area that I help out also. And then in medicine, I want to make sure before I treat something, I can rule out different diagnoses. I'm also sensitive to, making sure we address the GYN, mental health, and really working with a multi-specialist. And then the next one. So for education part, I've done some directions with CMEs, both at NYU and at Shriners, and then national organizations represented. The pediatric ITB network is a little bit more interesting because this one we co-founded with Boston Children's Hospital. So that's something that a nurse practitioner can also do. And then finally, for College of Nursing, we can teach pediatric NPs, family NPs, and doctoral nursing practice. Social prescription actually was born out of that DNP project. So as you can see, we're all learning, both Nikki, Dr. Ayman, and me. And then this is just the latest ones that we did. This one is a systematic review, and the other one is transition. And then these are just all the, we want to just keep the cerebral palsy awareness, cerebral palsy research network we work with. We're getting data for them also in terms of, what do you call this? We put together like information regarding cerebral palsy. And that's it for me.
Well, that's hardly it for you. There's you do a great deal. I want you to elaborate a little bit on your interaction with adolescent patients that are transitioning when they are no longer really have much pediatric orthopedic care needs, when they may not have any acute PM&R needs, but they are going to have more social issues going forwards. Talk a little bit about that and your role and what you can offer, please.
Well, that's actually the most fun stage because they come to clinic and of course there's some medical questions, but primarily the questions are, what do you want to do? What are your hopes and dreams? What would you like to do in college? Would you want to move out? How are you going to do it? And it's really more conversational with adolescents rather than kind of prescriptive. And then when we work with adolescents, we work around what they would like to do. And I think what's very helpful when we see adolescents is develop a peer group with them, because I've seen success with creating that peer group. An example was when we started NYC Ballet back in 2017, and then we went back after the pandemic, and there's like a groupie now of these adolescents. They're not adolescents anymore. They're young adults. So I was very happy to see that, and families, especially the ones who are with them. So that's it.
Terrific. All right. I am going to stop sharing. And let's see, questions. All right, here's a good question. I think this can go both to, I guess, for all three. Do you coordinate or partnership with CCOs from the Office of People with Developmental Disabilities to ensure the person who provides respite service at home after surgery is prepared to support the patient needs? Clearly, this is an important question. And Nikki, tell us, what do we do? What do you do to prepare the family for going home?
Oh, so for post-op.
And I'm sorry, and let's also talk about the other nurse practitioner that we haven't discussed, who is also really important in orthopedics. Jen Crotty, please.
Yeah, so preoperatively, we talk about all the potential needs. Post-operatively, We talk about the potential need for home PT, but also PT outside the house, because the home PTs, unfortunately, post-pandemic have been less voluminous, as it were. There are very few pediatric physical therapists, especially here in the city. So getting home services is a little bit more difficult for our pediatric patients. And sometimes we work directly with the OPWDD. Sometimes we work directly with a care manager for their insurance company. Sometimes the patients have their own case manager just on their own. We have our own care coordinator, Jennifer Pimentel, who also helps me because she has a few more resources than I do. And then Jennifer Crotty, who's one of our inpatient nurse practitioners, is also instrumental. So I directly send her a message before our patients are admitted, so that they are aware of the patients that are coming in, the potential needs post-operatively, so that they're sort of prepared, so that way they can actually get the ball rolling almost as soon as the kids hit the door for the OR. So that way social work and the nurse practitioner and the inpatient side are well aware of what the potential needs are. And then, if anything changes, then, we have sort of a baseline, but we at least have a starting point.
Yeah, this work is really important, and it gets done long before the incision is made in the operating room. It's really made when the decision for surgery is first made. And what we found is that it both alleviates, can reduce a lot of anxiety. It also can reduce the amount of time that the patient and the family have to spend in the hospital waiting to go home, or waiting to go to the next level of care, which might be a rehabilitation facility. So in that sense, it is very helpful to the patient and the family. I want to introduce another really critical member, non-physician member of the Weinberg Family CP Center, and that's Lisa Yoon. Lisa Yoon is a physical therapist. She's been with the Weinberg Family CP Center now. Lisa, how many years?
Well, I've been with the CP Center a while, but
Yeah, almost since the beginning,
yeah,
if not
but
the beginning.
but formally not so many years. Thank you so much for this presentation. It was so informative. I really enjoyed hearing about all the various roles. My name is Lisa Yoon. I'm part of the CP Center, and in line with kind of what Nikki was describing, the prescription to PT, we do now have a PT clinic for which we can take referrals from patients from the community. So if there is any kind of needs post-surgically or pre-surgically, the Weinberg Family CP Center also has a physical therapy clinic that patients can be referred to. And it's been really my pleasure to work with every single one of these nurse practitioners and the team at Weinberg. So thank you for letting me say a little bit about the new clinic.
Yeah, no, you're welcome, and I really appreciate that you've helped to put this together. And I'm looking forward to utilizing it. Finding skilled, interested physical therapists for people with cerebral palsy and other childhood onset disabilities is critical, but unfortunately it's challenging. And having somebody in our family is going to be terrific. There are a couple of questions about differences between orthopedists and physiatrists, or orthopedics and rehabilitation medicine. So I want to ask Elizabeth, when should a patient think about seeing a rehabilitation specialist as opposed to an orthopedic specialist?
Sure. So we really see anyone at any time in any kind of stage of their condition or any stage of life. You don't need to have a specific pain or specific question or concern. We like to do kind of like a whole body assessment, ask a lot of questions, talk about, like I mentioned, function. We're very big on talking about function and how we can help improve function if needed. So we like to emphasize that you can come see us at any time. I would say the biggest difference maybe, and correct me if I'm wrong, but if there's not like an urgent or acute orthopedic surgery need, then I would say come see rehab, and we can kind of help you with kind of all the things that I talked about in the slides and more.
Yeah, no, I think that's a really good point. We both specialties take care of musculoskeletal issues in people with disabilities. We come at it slightly differently with respect to what we offer. Orthopedic surgeons offer surgery to fix things, improve things. Physiatrists, rehabilitation medicine specialists offer therapies, medications, orthotics. But although I can recommend them, I don't pretend to know the breadth of these different modalities, the different types of medications, and the problems associated with them, the interactions that are important, as well as the different types, specific types of therapies. And that's where your expertise really does come in. And I guess most importantly, there are a number of patients, many patients, who don't need an operation. That's not what is going to help them. And what they really need is modification of their medication regimen, different types of therapies, a different type of therapist, or some other type of bracing, Botox. They might need intrathecal baclofen, or maybe they do need surgery, but not orthopedic surgery. Maybe they need neurosurgery, and this is where your expertise comes in and can help guide that patient.
And I would also say this also goes to one of the other questions that's on here, is that Elizabeth and I spend a lot of time sending each other messages about patients. Because if there's a kid that we are seeing that, the tone management we think needs to be a little bit more under control or something like that, or they've been elsewhere for their tone reduction, and it hasn't been fruitful, then I'll often talk to Elizabeth and send her a message and say, hey, I'm sending this kid your way. I think he needs a little better regimen. This is what I'm thinking, but clearly, I'm going to defer to her. But that's a fair amount of what we do is spending time communicating with each other. So we know most of the same patients, and it definitely helps in the long run.
Yeah.
Two other questions. First one is kind of quick. What insurances do we take? We take nearly all insurances. We certainly take most of the Medicaids. But it's hard enough for me to know anatomy. I can't begin to remember all of the insurances that we take, but our offices do.
Yeah, both.
And yes, and so if you call the office, they can certainly give you that information. But there's another good question, and that is, at what age should someone start seeing Eduardo? And I guess what the real question is when do we start thinking about transition? So Eduardo, let's talk about that, please.
I don't know. I mean, like any age. Well, I can tell you who I'm seeing. I've seen. Youngest will be an infant. The oldest probably 75 years old. So on my Monday clinic, the age range is between 29 and 74, and the aggregate is about 40s. It's such a privilege to work with this group of patients, because we need to get that information so we can prepare for the younger ones now. When I see them, particularly the much older one, the elder age, perhaps like around 65 years old, when I see them, one project that I'm thinking of is perhaps work with a geriatric group at Columbia. So that's one particular age that I see right now, and the rest pretty much who we see at the center. Because on Wednesdays I work with Peds Ortho group, whom we see a lot of CP patients with CP, and also with Jason Carmel. He's our neurologist. We see quite a few young and old. Same thing with Jason, young and old.
Yes.
too.
I would say it probably also depends on the goals, right? So if somebody is thinking about, finishing high school, going into college,
That would
Like,
be-
how does that transition work? Like, how can they find services?
Right,
You
right.
know, where they're going for school.
Right.
Are you transitioning from college to adult life? You know,
Right.
being an adult, which, you know,
And
isn't
what's your mobility going
Correct,
if you're
yeah.
going to college?
Yeah.
Because are you considering power wheelchair
Yeah.
in the university?
Yeah, I think those are all really good points. As far as I think the question as to when do you begin the transition discussion? You begin, yeah, you begin very early.
Very early.
And again, it goes to this notion that Eduardo raised about expectations. And I think one thing that all parents have in common is that they all have expectations for their children.
Yes.
Of course, the specific expectations differ given differing circumstances. But it's one of the issues that all parents again have is what will their child be like? What will their child's life be like as an adult? For a child with a disability, it takes a great deal of planning to affect the
Full
get to
potential.
that. That's right. Thank you. To get to that potential. So I think that this discussion really begins, just very concretely, really begins in the early teen years. And if I'm seeing a patient and Eduardo is with us in the clinic, and the child is 12, 13
Yes.
years old, I will bring Eduardo in just to begin that discussion, throwing around some of these letters and of organizations, OPWDD and so on, that I really don't know that much about, but Eduardo is expert in. And he can not only raise issues, but more often try and alleviate some concerns and anxieties that parents have.
Right. It's one of the most exciting time because I mean, not every patient is the same. I mean, all their goals, and then the parents too is another. So the adolescents, 12 years old will be a good time to start talking about it. But realistically, I start talking to the parents at around 8 or whenever I see them as a new patient. Of course, it's not going to be the focus of our talk, but I'll give mention. I want the parents, I think it's important for the parents to see that child, that, oh, my child can do that, or something like that. Like they have, I can give some vision for them, because this is all based on the patients I've seen, because they will start asking questions about them. And then like even a child, like I think we just saw a patient not too long ago, but the mom was just very afraid to send a kid to college. And then this particular patient was so motivated, so smart, and I end up, and what's good about it is both parents came with the patient. So I thought that was very revealing. So we kind of all compromised on something. I involved, IWD was involved also because of, because they have that particularly for girls group.
Good. Another question about lifespan is that, or not so much a question, but a statement, an issue that someone raised, was that of isolation of people as they get older. And that's unfortunately, it's very true. How do you address that? And I'm sure when you are talking with some of your adult patients, that becomes an issue. What do we at the Weinberg Center have to address that?
Formally, it can be called social prescription. So these are the non-clinical, outside of home, outside clinic type of activities that can give therapeutic effects. An example will be something cultural, right? We have NYC ballet. We have adaptive sports. This is not like physical therapy or occupational therapy, because I have to explain this to the parents, because they're going to be afraid, oh, my child can be hurt. And then you start explaining to them, no, this is it's an adaptive sports, different types of level of functioning of kids are enrolled in this particular program. So those are one of the examples. The other ones will be like for caregivers. Minelli, our clinical social worker, has programs for mental health, group for adolescents, also for parents. So again, those are non-clinical, but they're it provides platforms to both patients and the families. So
Yeah.
this-
I'm glad you mentioned Manelli. Manelli Vasquez is our licensed clinical social worker.
Right.
And not only does she see patients on an individual basis, but she has helped to develop groups,
Right.
both therapeutic groups as well as just social groups that interact together periodically. Some of them are actually driven by the participants themselves. And I think that offers an opportunity, additional opportunity for community, as well as sharing their own experiences, and hopefully helping to minimize and mitigate this issue of isolation.
Well, we have our care coordinator, Jennifer from Intelli. Will not be uncommon. I will ask, we need to find a Tai Chi program.
Yeah.
Where is the patient, you know, the address, and then Jennifer will, we're all problem solved. Balkis will be involved also. She's one of our senior administrative person at the center.
I'm glad you also mentioned Jen Pimentel, because care coordination is so important.
Right.
And it's something that none of us, neither nurses nor physicians, are taught how to do it. And thankfully, there are people who are educated and have the expertise. And Jen Pimentel is an absolute expert in this.
Yeah.
There's another really interesting question here, and that is, how do you work with nonverbal patients? Do you have departments supporting the use of any form of communication? Nikki, I'm going to ask you to address this. And Elizabeth, if you have any thoughts, please feel free.
I mean, it's purely dependent. We have a lot of nonverbal patients that come with parents and caregivers. I think first and foremost, we always talk to the patients, because, you know, the more often they have, if they don't have their communication system with them, because a lot of them have more elaborate systems that they have at their home, whether it's a Tobii eye gaze or, you know, other form of communication. A lot of them, you know, we rely on the parents and the caregivers to know them the best. They know them best. We only see them shortly for brief periods of time. But over the years, we learn a lot of the patients. And, you know, so I think part of it is that we do what we can to make sure that we understand how they can communicate. You know, what communications do you use? You know, how can we integrate that, you know, especially if they're having surgery or something like that, how do we integrate that with their post-op care? So I mean, it's really dependent on the patients. But yeah, a lot of it is, you know, reliant on, you know, talking to the patients, but also making sure that, you know, somebody, you know, also knows them best.
Yeah. Absolutely, but we also have the benefit of working with the occupational therapists as well as speech therapists at Columbia, who are very skilled in this, and they can also advise and consult with the families as to what, and the schools, what might be the best method of communication. And the breadth of techniques that are utilized is really just remarkable. Good. Let me see. Well, there was a thank you to Eduardo for underscoring the importance of managing expectations and highlighting the hope for the future and quality of life in our patients. I agree. I applaud you for that. There was one last question, I think, about research, and that is, do NPs do a lot of research typically, or is that more because of your specialty or history in education?
I think that's it has to do with interest. I have a lot of interest in research. It helps that I work in an academic setting, because it's, you know, sort of the hallmark of what we do in an academic setting. There's at any given time, we're, you know, have multiple studies going on at once. I'm sure Elizabeth agrees that, you know, it's working where we do, it's easier to do research, because we have the, you know, facilities and the background to do it, and we have the support. But anybody can do research. You can be an independent practitioner or have your own practice and do your own research. There's nothing to stop you but yourself. I think interest makes all the difference in the in research. And you know, having that interest in seeking more information. You know, we're always looking for more information, how to make things better. Quality things are always a big deal, but also patient outcomes.
It's I'll do a 30-second one. So I've never been interested in research. So what happened was our no, previously. Now we're like, oh, research. No, because Debbie Sala, she's a retired researcher at NYU. I'm always going to be indebted to her. She's really the one who pulled me on research, and then that's how we got into this descriptive study in healthcare transition, because it's such a complex issue. And then one revelation is that when you put your data together and you look at it from the drone view, you go like, oh, this is what's happening. And then you see patterns. And then you will ask different questions whenever you get involved in research. So from that point on, I think during the interview, Josh, I said, this is my last hurrah. I said, we will try to provide as much data, authentic data. What makes it authentic? Because we're not going to make it up. The data is going to come from the patients. I mean, I believe that I will never, not in this lifetime at least, right? But the data that we will produce, it will be built upon. So that's how I look at research. And for those patients without a voice, without words, the parents, the caregivers, it's so big to me. I'm such a different provider now because of that. And that's it. And I like research. No.
Elizabeth, what do you think about the research?
I just wanted to say that in work with people with cerebral palsy and people with disabilities, there's such a lack of research right now. So I think it's really important as providers who work with this population to be involved in research so that we have more resources and knowledge moving forward. The CP Research Network is a organization that works closely with Columbia, collecting data, and they have a bunch of different quality improvement studies and different special interest groups that are conducting different studies within the CP population. So one that I'm working on right now is kind of how we assess and then treat pain in people with cerebral palsy. So it's a 3-year-long study that's kind of implementing questionnaires or certain questions of how we kind of address the topic of pain, because it's there's such a wide range of pain and types of pain and causes of pain, especially in people with CP. So that's one thing that we're working on right now. But I think because of the lack of research, we need to be more involved in research, specifically for our patient population.
Agreed. Listen, I want to thank everybody for participating in today's webinar. I hope you found it informative as well as enjoyable. We're going to do another one in just another couple of months. We have, as I mentioned earlier, we're going to have one on the medical management of spasticity. We will have an additional one on the surgical management of spasticity. But we really want to hear also what you all would like to learn about. And if you have any thoughts, please feel free. You can enter it in the chat. You can also, of course, call up the Weinberg Family CP Center and speak with one of the people there and give them your thoughts about it. So we would look forward to hearing from you. I want to thank I want to thank the participants for the time that they put into this. And I want to thank Jacqueline Chen for helping to organize everything administratively and technologically.
The producer.
Yeah. Despite my difficulty sharing stuff in the beginning, I think it's gone very well. So thanks, everybody. And I look forward to seeing you in a couple of months.
Thank you.
Thank you.
Bye.